There are studies that show the impact of chronic itch are equivalent to the impact of chronic pain. And I think people feel like they're not understood when they're presenting with a problem that really includes pruritus or itch as one of the primary features.
Welcome to the LearnSkin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
Hey, Hadar. You know, I can feel spring just turning around the corner. We already sprung forward, and you know what spring in the air means? More pollen, more eczema, my friend. I know it personally.
Yes, absolutely. And even though we talked about it many times, it feels like atopic dermatitis is this disease that we always see in our clinic. Every time we talk about it, I learn something new. It's just a wealth of information out there. Actually, it comes out rapid fire through the literature. It's really hard to keep up. And so that's why I like every now and then to bring an expert, sit down, have a real talk about atopic dermatitis and how it affects our patients. Shall we do that?
Yeah, let's do it. And you know what's really cool? We had an explosion of research in psoriasis over the previous decade. And I feel like over the past 5 years, atopic dermatitis has just really expanded. And it's been awesome for our patients. But don't take it from us. We're going to talk to an expert, Dr. Lacey Kruse. And she is an associate professor of pediatrics and dermatology at Northwestern University. And she's also a director of the Pediatric Dermatology Fellowship at Lurie Children's Hospital of Chicago. Welcome to the podcast, Lacey.
Thank you. Thank you so much for having me. I'm excited to be here.
Well, you know, Lacey, we appreciate you joining. And maybe just to get things kicked off, you are a pediatric dermatologist. So I'm sure there are a lot of clinicians out there. Many people know what a dermatologist is. What makes you special in terms of being a pediatric dermatologist?
Sure, that's a great place to start. So a pediatric dermatologist is a dermatologist who is board certified, did their residency in dermatology, and then spends an extra year in fellowship to learn specifically pediatric dermatology just to care for patients who are 18 years or younger. And so we see a lot of, a really broad range of diseases from birthmarks to atypical moles to probably one of the very most common things we see in our pediatric dermatology clinics is atopic dermatitis, because we know atopic dermatitis affects 10 to 20% of kids in the US. So somewhere between 1 in 10 and 1 in 5, it's very, very common. And for some of those kids, it's really mild. For some, it's more moderate or severe, and they really need us. So it's a really gratifying field. I love what I do, and I feel really lucky to have found it.
You know, one of the things we like to ask our guests, especially when you have something so specialized, is what made you go in that route? Because it's not the more common route, right? Most dermatologists practice adult dermatology or a mixed, and you chose to focus on the kiddos. How did that happen?
Yeah, I think like many people in medicine, you sort of find your field based on mentors and experiences you have along the way. I went into medicine just because I really liked science and I really liked working with people, and it was sort of a way to intersect those things. I found dermatology just by doing a rotation and really enjoying it. I liked the fast pace and getting to see a really wide variety of patients, lots of different types of issues and lots of different types of patients at the same time. I did a rotation when I was a resident in pediatric dermatology. It's not required for all residencies, so some residents get very little exposure to peds derm. But I was really lucky to have a really great experience. I actually rotated at the institution I'm at now at Lurie Children's Hospital and had a really great experience there, learning so much about pediatric dermatology and really just opened my eyes to, like you said, a field that not a lot of people even know about. And so I will put in a plug for pediatric dermatology. We are a very small workforce with a huge demand. It's a great field. The happiest doctors I know are pediatric dermatologists. It's a very gratifying field, taking care of kids, really improving their quality of life. So it sort of found me, I guess, is the short answer to that.
I can attest. It's true. probably the happiest group in dermatology are the peds derms, walking around cheerful and happy, because one of the benefits is that most of the time kids are usually healthy and they may have a very specific complaint. And so the management makes it a lot clearer. You really are tackling one issue. Now, talking about tackling an issue, atopic dermatitis can be certainly very devastating, even at a very young age. And I wanted to ask you, because we are now in an era where we got actually pretty efficacious therapies. And I think that allowed us to move away from just seeking treatment to get the disease under control to explore other aspects of atopic dermatitis that I think before we knew existed maybe, but we really didn't pay much attention. And I'm talking about the psychosocial impact of the disease on both the patients and also the parents. I think the entire family unit is basically involved. So it sounds kind of intimidating, but maybe you can break down to us how you think when you see a patient in clinic with atopic dermatitis, and let's say the disease is under control or not, how do you approach this? What kind of problems you have to deal with when considering the psychosocial aspect of the disease?
Yeah, I have a lot to say about everything you just said. So first of all, I totally agree with what we were saying earlier. When I was a resident, I finished residency 10 years ago. We really saw this revolution in psoriasis where suddenly all these therapies were available. And frankly, patients kind of coming out of the woodwork, hearing about them, and a very exciting time to be treating patients while you're really watching medicine change and being able to offer treatments for a disease that even just a few years before we had very little. I totally agree that that's happening right now for atopic dermatitis, and it's really, really exciting. And typically when a new therapy is available, it's available in adults, and then maybe many years later, sometimes even decades later, we see that trickle down to pediatrics. So for us, it's a very exciting time that not only do we have this sort of explosion in systemic agents available for atopic dermatitis, but we're actually able to use them in pediatric patients on label. And that's really a unique gift I feel like we've been given. Another thing sort of from the question stem here, I always tell families atopic dermatitis is a disease for the whole family. If the child isn't sleeping, no one is sleeping. If the child is itchy, no one is going to be able to feel comfortable. As my dad likes to say, you're only as happy as your most miserable child. And I think that's what it's like to be a parent.
That's amazing. Fantastic.
So I think it's so important to think about the psychosocial aspects of atopic dermatitis for the patient, but also for the parents, for the siblings, for the entire family. It really, the impact on quality of life and mental health is really significant and sometimes extreme for these patients and families.
So, maybe we can break it down a bit, and maybe you can tell us more about how itch as a specific symptom in atopic dermatitis. So, maybe you can tell us specifically about itch. This will help us to break it down and think about it maybe more. Like you said, it's a huge topic, right? Psychosocial. How does itch specifically affect the behavior of kids, maybe in school, their sleep? How does that contribute to the psychosocial impact in eczema?
Yeah, so itch is one of the hallmark features of atopic dermatitis. It's one of the major features when you look at the diagnostic criteria. And so these kids are truly extremely itchy. And I think for people without atopic dermatitis, sometimes it's hard for us to understand really the impact that has on quality of life. And sometimes when I talk to parents about this, I talk about like, sometimes if someone has even 1 or 2 mosquito bites, they'll have a hard time sleeping because they're so itchy. But this is the kind of thing these kids live with every day. And it's not just 1 or 2 mosquito bites, it's sometimes their entire bodies. There are studies that show the impact of chronic itch are equivalent to the impact of chronic pain. I think it's underassessed. We don't talk about it as much. We don't have directed treatments at itch like we do pain. And I think people feel like they're not understood when they're presenting with a problem that really includes pruritus or itch as one of the primary features. But we know that the impact on quality of life is huge, right? Not only is it really, it doesn't feel good and there's a huge impact of that, but the impact on sleep is significant. Patients with atopic dermatitis are more likely to have sleep disorders. They're more likely to have depression and anxiety. It really is a burden for these patients and families. And again, I think we're in an exciting time where we have many options as to sort of how to go about alleviating that for them.
Lacey, can you talk a little bit about, because obviously itch is such a huge driver in quality of life. And I mean, gosh, when one of us has an itch, or, you're in surgery and your patient has an itch, they're like, oh, I can't stand it. I can't imagine the entire body like that. How do you measure itch, especially in children? Do you take the word of the parents, or is there a different way to measure it? Maybe, when they're really young, how do you assess that?
I think assessing itch in children and even in adults can be challenging. There's not really, validated itch scores or anything like that. Again, I think it's sort of underrepresented when compared to chronic pain or even acute pain. But I think there are lots of clues. So number one, we can always talk to the patient if they're able to talk, right? Some of our younger patients, we have to use other clues, but often they're willing to tell us. So when patients are asked what's the most bothersome symptom of your atopic dermatitis, their almost universal answer is itch. When parents are asked what bothers you the most about your child's atopic dermatitis, their almost universal answer, again, is itching and scratching. So I don't think that there's a lot of confusion like amongst providers in the family as to whether or how itchy the kid is. I think typically people are pretty aware of how miserable the patient or the child seems. In younger kids, I do think it can be a little bit harder. Sometimes I have to point out to parents that their child is scratching, especially in younger babies who don't have the dexterity to actually scratch with their hands. They'll do things like rub their cheeks against the parent's clothing for itching the cheeks, or rubbing the head against their crib, or in clinic, the exam table, to try to get some relief. At the same time, sort of conversely, we know scratching often makes atopic dermatitis worse. It can make the itch worse. And so it sort of leads to that cycle. But I think, we probably could use more validated ways to measure itch, but subjectively, I think patients are telling us as long as we know what to look for and what questions to ask.
What's your thought on this numerical rating score that a lot of clinical trials are using, 0 to 10, and they look for that 4-point reduction? Do you ever use that clinically?
That's a good point. So there's lots of tools that are available to us in research that we don't necessarily use in our clinics consistently. I do find actually sometimes I use some of these scales when I'm starting to think about drugs in particular that I might have a hard time getting covered. So doing a validated measure of eczema severity or itch can be useful. But a lot of those are more tools that we use in research rather than clinically. But they are available. And so that's a good point. If and when it's needed to sort of demonstrate the level of itch, I think those can be useful. In clinic, I think typically the parents and the patients, if they're old enough, there's not a lot of confusion as to how itchy the child is. Parents are telling us things like, there's blood on the sheets in the morning, or we can't get him to stop scratching, or whatever it may be.
No, I appreciate you saying that, because, just in the clinical trial space, a lot of us will use a numerical rating system as a validated score, and with 7 and greater being severe. But I wondered how much it translates into the clinic for you, especially. I'm curious. So you don't use that score clinically. You just find that talking directly to the parents makes more of a difference.
Yeah, and I think the place that it might be useful is I can think of a few spaces where doing something sort of more standardized would be helpful. One is when someone has mild eczema, sometimes we think they're not really experiencing so much itch, but they sometimes are. And so I think that's actually really important. Typically, again, I can sort of just talk to people and ask them, but I think sometimes we might be surprised at where they would put their itch on a numerical scale. And the other is when I think eczema is under good control, but then when I talk to them about itch, they might look good on exam, but they're still feeling really itchy. And so to me, that's actually more important than what I'm seeing clinically. If they're still itchy, we haven't met goal, right? So I think A, sort of demonstration of response to therapy, a standardized scale is useful there. But B, sometimes I think we might be surprised at what we would hear if we asked that to every patient clinically. It's more just doing everything in a busy clinic sometimes can be challenging, but I think more so than using a standardized numerical scale, I talk to the patients about how they're doing and sort of ask them, how itchy do you still feel? And if they're not satisfied with their level of itch, then neither am I, right? Or sometimes even vice versa, they think it's okay, but they're actively scratching. And we have to talk about how, maybe you've lived with that itch so long that you're not really thinking about how much it's affecting your life anymore, but it's clearly there, right?
It's such a good point. Like, we can obviously get wrapped up in these scales, which, obviously they are important in the research world, but like you're saying, someone can still be itchy. And so I'm sure you're looking at so many context clues, and I love the clinical kind of approach to that. Now, another question I have for you, what about children that have darker pigment? Are there unique challenges that the parents may be concerned with or the child may be concerned with, just socially speaking? Is that something that you have a discussion about?
I think there's a few things to think about there. One is sometimes I think clinicians actually underestimate how severe eczema is in skin of color because you're missing that sort of erythema clue that shows the extent of the disease. So you can still see the thicker lichenified plaques, but it can, I think, unless you're looking for it, sometimes there are areas that might be involved that aren't so obvious. And the other is, I think, thinking about post-inflammatory pigment changes, both hyperpigmentation and hypopigmentation, which are common in all skin types, but more dramatic and more common in skin of color. So atopic dermatitis, as a plaque clears, can leave a light spot, can leave a dark spot. And, I think as clinicians see that as improvement, it is, the dermatitis itself is better. But for patients who are bothered socially by the appearance of their skin, having a spot sometimes is having a spot, right? Whether it's an active plaque of dermatitis or hypopigmentation or hyperpigmentation, to them it's still there. And so sometimes I think it impacts our treatment goals and just sort of how we're approaching those patients. And again, I think when I talk to patients about this, the best way to prevent hypo or hyperpigmentation is sort of escalating treatment so that it doesn't get to that point. But sort of just another conversation when we talk about goals of therapy.
Lacey, you actually bring up a good point about goals of therapy. And I think that there's two things I want to ask you. First of all, I want to ask about escalating therapy early to prevent this hypopigmentation. I think that's an interesting point. And the other thing is, do you find that when you actually treat the disease effectively, you're resolving most of the psychosocial impact, or there's some residual impact that is left after? So 2 questions, but you can answer one at a time.
Yeah, I think for patients, especially with skin of color or patients who just really have prominent hyper or hypopigmentation, if that's bothering them significantly, it makes me think about being more aggressive with therapy. And that can mean many things. So it might mean just really more consistent skincare to prevent new flare-ups, because every single new flare-up is potentially, or sometimes probably, or even certainly going to leave a pigment change behind. So the more we can prevent those flare-ups, the more we can prevent the pigment changes. And sometimes also escalation to systemic therapy. So if your atopic dermatitis is moderate or severe, where we would be thinking about a systemic therapy anyway, sometimes those persistent spots of hypo or hyperpigmentation are kind of what drive us to think about escalating therapy as well. So the dermatitis itself has to justify the therapy, but I think those persistent stuck behind patches, which to our patients are scars, right? That's what they often call them,
right,
are part of that equation as we're talking about, what are our next steps here?
No, I love this. And that's really what makes a difference between a human doctor to an AI algorithm, because you actually look at the patient and try to think, wait a minute, I need to maybe escalate. So I love that. I wanted to ask.
Chat DOC instead
Exactly.
of GPT?
Exactly.
Right.
Thank you. Yes. And I wanted to ask you also, Lacey, kind of going back now to the psychosocial impact. Do you find that when you actually treat the disease effectively, and we mentioned now we have effective therapies, not great for everybody, but certainly big difference, that big impact that we can make on the disease. Now, do you find that when you reach this kind of effective therapy and the patient's skin disease is improved, do you find that also the psychosocial impact is improved, or are there some other residual impact that clinicians should pay attention to?
Yeah, that's a really good point. In my experience, and I think we don't necessarily have a lot of data yet on some of our newer choices for therapy, but I have many patients in my practice that maybe I've followed for years. And so now finally we have some options that might have just become available in their age group, or they're just sort of ready to start thinking about some of the more aggressive therapies we have to offer these days, the more effective therapies. I think when we're able to escalate to those, most commonly I do see a dramatic improvement, at least from my perspective and from talking to the patient, in a lot of the psychosocial impact of atopic dermatitis. Particularly, I think we all can relate to if you had a disease that kept you from sleeping every night, and we were able to improve that, your psychosocial outlook on life is going to be dramatically improved. I think what's yet to be determined, and especially as we're treating younger and younger kids, is I think when we think about the psychosocial aspect of atopic dermatitis, at least for me, I'm thinking about the itch and the impact on sleep and the social burden, bullying at school, being teased by friends. We know that kids with atopic dermatitis are less likely to play sports because they feel itchy when they sweat or they're embarrassed for people to see their skin. And I think those are the parts that are pretty clearly improved when we're able to improve the disease. I think the part that's less clear is the association with true legitimate mental health disorders such as anxiety, depression, and ADHD. And I guess my hope is yes, probably. And I think that that'll be something really interesting to look forward to in the future.
Lacey, you bring up excellent points there, because I think now we're getting to the era that some of our inflammatory skin diseases like atopic dermatitis and psoriasis, we can achieve great control, right? I used to call it like the IL-23 or IL-17 visit with a psoriasis patient that's completely cleared. Now, what do we talk about, right? And I think that we need more data to know how the residual effect of inflammatory skin disease, and usually we'll talk about moderate to severe diseases, be it atopic dermatitis in this case or psoriasis and others, how does that leave an impact from the psychosocial aspect on our patients? And do we need to address it? Because patients come to us now, there's no real skin burden anymore. Everybody's happy, everybody's smiling, it's a quick visit, everybody's doing great. But then, wait a minute, are there questions we need to ask? And I think we're just scratching the surface, no pun intended.
Well done. We needed a dad joke in there. I think we got our quota.
We got our quota, Roger, right? Thank you for bringing that up. Now, I wanted to ask you, clinicians who are listening right now, what do you think is the one take-home message they should think about when it comes to the psychosocial impact of kids with atopic dermatitis?
I think for me, the biggest thing is I occasionally will see a kid who's been told something like, oh, you'll grow out of it, or it's potentially been maybe minimized, atopic dermatitis, oh, that's something that most kids outgrow, or I guess even more so just undertreated. I mean, this is a disease with significant impact on the child, on the family, on mental health, on sleep. To me, it's one of the most gratifying and important things that I treat. It comes in all varieties, right? There are kids who just have a little bit here and there on their hands or arms, and then there are kids who are covered head to toe. But I think really in any of those circumstances we have, especially in this day and age, so many opportunities that we can offer to these children and families, treatments and therapies and skincare, and really holistically treating them and improving their quality of life, minimizing their itch, improving their sleep, and potentially, impacting their risk of mental health problems in the future. So I think it's really one of the most gratifying things to do. I would encourage all clinicians to become very adept at treating eczema. It really is just so gratifying. I think many providers don't get a lot of exposure to dermatology, to treating atopic dermatitis effectively. So I would encourage people to seek that out and get really good at it. I think there's lots of CME available and things like that can really give you these tools to make an impact on these kids and also adults' lives.
Well, I could have not said it better. So thank you very much. You guys were listening to Dr. Lacey Kruse talking to us about the psychosocial impact of atopic dermatitis. Definitely a lot has been accomplished, but we need some more information about next steps. So we look forward to that research. And Dr. Kruse, thank you for your time, for your expertise. I appreciate it.
Thank you so much for having me.
Guess what, Hadar?
What?
Tickets are selling so fast for the 6th Annual Integrative Dermatology Symposium.
Really? Wow, that's amazing. I mean, each time this event gets better and better.
Yes, it does. And as a special gift to our podcast listeners, all of you, we're offering 15% off registration using the code PODCAST15.
PODCAST15 for 15% off. That's a great deal. And prices won't be going any lower this year, so hurry up and get that discount.
So true. And if you haven't joined us in person yet, we can't wait to see you. And this is the year to come have fun at the Grand Casino Resort in Reno, Nevada.
Yes, we are excited to see you, and together with Raja and myself and other practitioners, you will get to connect with everybody, engage with the exciting research and content, and learn what the integrative movement is all about as we get inspired by the Sierra Nevada mountain range and, my friend, downtown Reno.
All that nestling sounds fantastic. Dad joke alert, maybe even skin-tastic. I know we're all about having fun at the symposium, but this year's over the top. Now, I'm not much of a golfer, but for you golfers out there, they have over 40 courses, but they also have rock climbing, equestrian trails, boat tours, pools, arcades, and so much more to just relax.
Oh my gosh, this definitely sounds like a family-friendly getaway. I know I'm bringing the kids, and while they're at the movies, Raja, you and I, my friend, no pun intended here, but we'll be feasting on a lot of nutrition.
That's right. This year's theme has been long awaited. Nurse the gut, nurse the skin, and we'll be delving into nutrition.
Oh my gosh, we can't wait to see you. Come be with us at the IDS on October 27th to the 29th, in person or virtually. See you in Reno.